how do we learn to be our own advocate? You know, we were having a discussion earlier with one of our patients here about how it's important to basically take charge of your own care and to know what questions to ask, know when to see a doctor, when to get a second opinion. Is it okay to get a second opinion? How do you advocate for yourself? How can the doctors help that, make you feel comfortable, and how can you feel comfortable with that? So with that said, we have a panel of doctors and patients, so I'm so honored to be here on the stage with, who are going to learn from each other and share experiences. And so I'm going to introduce the panel, and then I'm going to kind of ask questions, and I'm sure we'll kind of have a nice natural discussion too as we go along as well. But just for the introductions here, I have Julie Grutzmacher, is that right?
Yes.
I was practicing. The Director of National Collaboration and Engagement to Prevent Blindness. So thank you for being here. We'd love to hear your thoughts as well. We have Dr. Lisa Rosenberg, who's a Clinical Associate Professor of Ophthalmology at Northwestern. There you go, right in the chair there. We have Dr. Lisa Young, who's an optometrist at Chicago Glaucoma Consultants as well. And we have two patients who are going to give us a lot of real-world feedback on what it's like to have glaucoma in different stages of glaucoma. We have Phillip Edward Van Lear, who's a glaucoma patient who learned as a fellow musician and percussionist as well. We learned that we've had some connections in the musical world earlier with Funkadesi. And then we also have Caroline Wolfe, who's also a glaucoma patient. So thank you all for being here and looking forward to sharing and hearing from you all. So I guess I'm going to start us out with just asking a question, and a very simple question. I'll ask Dr. Young. When should a patient see a glaucoma specialist, or should they start with a general eye care provider, or how do they know what to do next?
I think that's a great question. The eye world is so comprehensive, but yet each provider oftentimes has a little niche that they're great at. And so whether you're diagnosed with glaucoma by your optometrist or a general ophthalmologist or a glaucoma specialist, all of those providers can be part of your eye care team. And I think team is really the best approach when we think about glaucoma because, well, we all know some great doctors maybe aren't great communicators, or great surgeons aren't great communicators. And there's different parts of the eye, and there's different aspects of glaucoma that we think and talk about. We talk about treatment, we talk about eye drops, we talk about surgery. But let's also, too, talk about your overall daily function and how we address your visual needs. And so it's reasonable to see an optometrist for your care, and maybe an ophthalmologist, and maybe a glaucoma specialist. And at each point along the way, it's reasonable to have a conversation to say, hey, is there someone else that I could bring into my team to help better my therapy, my treatment, my vision? How can I move forward and be the best that I can in terms of my overall management when it comes to my vision and this disease?
That's a really good point. The collaborative care you talked about, this team, we co-manage with optometry and primary care ophthalmologists as well with post-glaucoma surgery, pre-glaucoma surgery, and having that communication is so important. From the patient perspective, what is it that, how do you prepare? Did you prepare before you went to your eye doctor, your glaucoma specialist? Love you, Caroline, would you like to answer this question on kind of what did you prepare? Do you have to prepare, or do you just kind of go in there without any knowledge yet with that first visit?
First visit, it's kind of overwhelming because you have just found out that you probably do have glaucoma. I also found out during COVID, like in the end of February of 2020, that they thought I had glaucoma, so it was a matter of going to some specialists and then delaying any kind of a treatment for a while because of the pandemic. So yeah, it was a shock, I have to say. And then also from there, though, I was first to Chicago Cornea, which my ophthalmologist thought that I had a cataract, which that I do, but that wasn't the main cause of the vision loss. So from there, then it was a matter of them sending me over to my next doctor, and I had a series of doctors and MRIs and everything else to rule out any type of a brain tumor or whatnot for the vision loss. And I ended up at the Wheaton Eye Clinic, and I see Dr. Ruth Williams, who is excellent in my opinion.
She's fantastic.
And I've seen many doctors in that clinic and had a lot of testing done. And so I'm still kind of coming to terms with the whole glaucoma diagnosis, and it's interesting because I have low tension glaucoma, so the normal tension, but my eye pressures are very low, and they'd like them to be even lower, but I still have pretty severe vision loss at this point. and I just found out in September of 2020.
Well, I want to ask you some more questions on top of that, because I want to kind of follow up with kind of your experiences and how you kind of came to grips or how your education was. But Dr. Rosenberg, I would like to ask you a question on how should a patient prepare? Is there anything they should do, research, or anything they should do before they come to that visit with the doctor?
I think your story is so common and usual, because you don't go to the eye doctor thinking you're going to come out with a diagnosis of glaucoma because there are no symptoms. And so oftentimes, most of the time, glaucoma is a surprise diagnosis. And there is a lot of information. As a glaucoma specialist, realizing this, I try to break the appointments up into pieces on how much information I'm going to convey to a patient at any one time. And likewise for the patient, to absorb the information bit by bit. So it is a process. It's going to be in large measure, decades-long relationship that I get to have with my patient with this condition, which is why I chose this as my subspecialty. So preparing for, there's the new patient, which either at the first appointment or the first follow-up appointment will hopefully become familiar with what the doctor said, do a little research, and bring a bunch of questions. They might not all be answered on the first appointment, but it'll build based on the answers that your doctor will give you. Subsequent appointments, let's say for an established patient who is already on some sort of treatment or treatment is planned, bring your drops if you're on drops, or keep a picture of your drops on your iPhone or your Android so you don't have to remember to bring your drops every appointment. And then when your physician asks you what you're using, how you're using it, it's great to just, here's this one, is this one. They're hard to pronounce. It makes it much easier. You'll gather your questions, maybe bring a family member or a friend for a second pair of ears when you're early on in your condition. There's still a lot of information coming. So those are some for suggestions. Getting further into management, some good questions I think to ask your physician is, what kind of glaucoma do I have, and what is your plan for management for me? Once management begins, you might want to know what your eye pressure range is. That's the only objective measurement your doctor can make about you. Yes, we can measure your acuity, but it's really subjective. We can measure your optic nerve, which is also objective, but the visual field is also subjective. There's a range of eye pressure, but what's most important is what's happening at your optic nerve and your visual field. Those together are all complementary pieces of information that are going to guide management for your condition.
That's a great point. And I think, you mentioned, this idea of making sure we have enough education on the front end. The first visit that I think we have with our patients is such an important visit to establish kind of the ground rules. So what to expect, what is glaucoma, why are you going to take that visual field every year, maybe more, do that nerve thickness test, and why we have to wait to see if you're changing over time. What is that target range and how that range may change depending on how stable you are. The more we can educate our patients, the better I think I have found in our practice, the more likely they are going to come back for follow-up visits. And I want to bring this to your point, Phillip, here about taking drops, because I think one of the issues I face in medical management of glaucoma is the frustration of compliance. How do we keep our patients on medications, going to get refills, going to come back and following up every day, not forgetting? How hard is it to take medications to remember, and how important is it to remember medications Phillip, from your perspective? And are there anything that you can do to help other patients get better at remembering medications?
Are you saying that we have issues with compliance?
Well, I've heard from some doctors.
Rumor has it. When I was first diagnosed in 2020, I did not know what I didn't know. And something you said earlier, doctor, there is something we deal with as patients, glaucoma patients, there is acceptance. And I really didn't have a difficulty accepting my medical condition. But I've learned over the years that there is a difference between acceptance and compliance. And just because I accepted the disease, I was not a compliant patient. Now, what I learned over the years, now dealing with being at the University Eye Specialist and now with Dr. Hawkins at Geneva Eye Clinic, is there is a certain amount of accountability that we have to accept as patients in terms of our compliance. What I've done now in the last 10 years, especially since my open angle glaucoma has become end stage, is that I set alarms on my phone. And my wife will tell you, they go off at the most inopportune times. 7 a.m. eye drop time, 7 p.m. eye drop time, that 12-hour period. What I, at the behest of Dr. Hawkins and Dr. John Yang, they always remind me, make sure you take that 5 minutes in between. Mm-hmm. Now, when we learn not only to accept our disease, but then we take an active role in that self-advocacy, compliance becomes much easier. At least that's what I've discovered over the years.
Why do you think it is so hard for patients to remember to take medication? I mean, I hear all the time, well, I take my real medications, my pills for high blood pressure, but I forget my eye medications. So there's some disconnect. And as a patient, both of you guys, why do you think it's so hard for a lot of patients to remember to take even a once-a-day drop, if that's true?
You want to answer that?
Well, I'm a rule follower, so
Okay,
when
good.
the doctor says take my drugs, I actually do it. So I also don't want to lose any more of my vision. I think that's the end game here, is to keep it as long as possible. So when I'm supposed to take my eye drops every 12 hours, I actually do it. And I set alarms on my phone, because otherwise I will forget. You forget these things. So.
Yeah, and it's such an important concept, because if we don't take our medications consistently every day, there's a chance that the pressures may go up and down. And some studies, depending on your glaucoma, show that we may have more risk of getting worse if our pressures go up and down as well. And so I'd love to ask Kellen about kind of being an advocate. You mentioned earlier on Phillip about the importance of being an advocate for yourself and for your own condition. What does that mean to be an advocate, and how important is that?
I would say to be an advocate is really to take action on the issues that are important to you. Advocacy is really taking action. To me, healthcare is meant to be participatory. So to be an advocate is to really, examine, the things about what are the barriers that I'm having with, taking my medication. And it's important to, I think, for the human spirit to feel like they have some agency and some involvement in their care. And so I think it improves, outcomes as well and management.
Yeah, it almost seemed like it's for me. It's like, are they engaged? Do they have vested interest? Sometimes, and sometimes as a clinician, from us as doctors, some clues for me. I'd love to hear your thoughts, Dr. Young and Dr. Rosenberg. When you hear a patient say, "I don't remember the name of medication, or the color of my tops, or how often I'm taking medication," does that clue you into maybe someone doesn't have that understanding, their education, or basically the vested interest? Any thoughts on that?
Yeah, in the olden days, the classes of eye drops always had the same color top, so you didn't have to know how to pronounce the names, and they were made by just a few companies. And now, so yellow was a beta blocker, and purple was an alpha adrenergic. Now it's a little more mixed up, which is why I think just the picture on the phone or some notation, even handwritten, is helpful. I want to digress for a moment about this compliance question. And I am guilty, but I wonder, of patients in this room, how many have been asked by their physician to show the physician or the eye care provider, optometrist, how you put your eye drops in? Can you, or show of hands,
how many people have had
if
that
your
happen?
doctor asked you, show me how you instill your drops?
Never.
Zero?
We have one. So what does that mean to you, Doc?
So this is a thing, because we know how to take pills. If there are any diabetics who are taking insulin injections, you were probably shown by somebody, some eye care provider, how to inject yourself. But we don't do this enough. And you can find videos online of patients attempting to put eye drops in and doing it incorrectly. So you might think you're compliant, but not getting the drop in your eye. So this is another question that would probably go far to make sure, could you watch me put my eye drops in and I'm doing it correctly? Do you hit the tip of the bottle to your eyelid? Might contaminate the drop. Are you getting one drop in? Is it a cause you miss a lot, so that's why you're running through your bottles so quickly? Because the pharmaceutical companies will tell you should have enough in that bottle. If a patient tells me I'm running out at day 20, well, they're squeezing out more liquid than needed. So I think that's a big issue for compliance.
And that's a really good point you brought up. And us as clinicians have to sometimes be a little better at cluing in on, and myself included, by the way, on cluing in on these what we call clues to non-compliance. So if someone says to me, hey doc, my vision comes and goes every day when I'm watching TV or reading a book after 5 minutes, I have to look and see, is the surface of the eye dry? Can I at least acknowledge that for the patient? Or if it is an issue, doc, do you have a sample every time they come in? Doc, I need a sample to get through this next month. That's a clue that this is probably a patient I can't give samples forever because I don't get enough samples sometimes, even though I want to give everybody samples if possible. Or if it's a situation where they don't remember the name of the medication, the color of the top, or how often they're taking medications, that should clue us as providers to say, hey, let's address compliance a little bit more and try to do something to help that patient. And the physical attributes, can they physically take it? If I have a patient who I'm going to start on a drop, a lot of times I'll actually ask a patient, here's an artificial tear in my office, take an artificial tear in front of me and see what happens. And you'll be amazed at how many patients are having a hard time. So it's a really, really good point. I'd love to ask you as well as Dr. Young, there's what I get questions a lot of times from patients. Well, my friend, his pressure was 20, but while you're telling me my pressure has to be 15, or middle teens, they're in the upper teens, or they're on one medication, you're telling me I'm taking 3. Why is it different? Any kind of thoughts on how we have to tailor the condition or the treatment and how we figure that out, just basically? Want to take some of that?
I think the key is what's normal for me, maybe not normal for you. And so that's oftentimes one of the misconceptions. When you do an eye exam, a lot of times the patient will say, well, what's my eye pressure? And again, maybe it's 15, maybe it's 20, but if we go back to the ocular hypertension treatment study, 20 may be normal for somebody. And so it's not really about the number, it's more so about the comprehensive testing and the nerve and all of those other things that we've talked about today that go into a glaucoma diagnosis.
Absolutely.
So for example, building on that point, the 3 variable, Dr. Tana showed the slide of the risk factors, greatest risk factors for glaucoma. There were only 3 things on that slide that are going to change. Your cornea is not going to change. Your age is going to change. Your visual field is going to change. And your eye pressure could change. So those parameters indicate for me kind of what eye pressure range I'm going to choose for my patient. How old the patient is. A younger patient who has a longer visual life, no disrespect, might have a more aggressive treatment plan than someone who's 85 with very mild glaucoma. Their prognosis is excellent. It depends on the visual field. More visual field damage, I'm going to go for something more aggressive in their treatment. Also depending on their age horizon. I don't have a crystal ball, but there are actuarial tables, and we kind of get a gestalt on how quickly someone is progressing or not based on how many visual fields are done, the frequency, and we get a rate of change of how fast that visual field is changing for a given patient. And choose that eye pressure range based on that. So that would account for the level of eye pressure that's chosen for any given patient.
Oh, okay. This is a good question from the audience. I'm just going to switch things around because we have a really good question here. Thank you for the questions from the audience. And anyone can answer this, one of the patients or doctors, but first the doctors. If the doctor only has 15 to 20 minutes per patient, or even less, right? How do we ask for questions or have more time for questions? Patients feeling that they don't have enough opportunity to ask questions. So I'd love to ask from the doctor perspective and the patients as well, and maybe from the advocacy perspective. So Dr. Young, why don't you any thoughts on how to gain more time with the doctor?
Good question. I think it's important to come to your appointment with your questions in hand it's great to communicate those as well to maybe the staff or the person that starts you. And then that way, when the doctor, you have that time with the doctor, yourself and the doctor can prioritize what needs to be addressed initially and how we approach following back up and maybe spending more time answering all of the questions. But that way you can prioritize what needs to be answered and what's most pressing.
Dr. Rosenberg, what are your thoughts on
I think,
getting more time?
If I have a patient who has a larger number of questions that I can't answer in the time period, I will offer them a follow-up appointment or a follow-up phone call. And I'll say up front that I have this amount of time. I would love to spend more time with you, but we might have to divide this up into sections. So that's someone with a lot of questions. Also, over the years, I've learned to kind of hone my answers to them, give them a target, give them a framework to think about the answer I'm giving them that will then lead to the next appointment. It's tough to not be able to spend more time. Sometimes a time of day is easier, like at the end of the day when I don't have other patients following behind. I'll have them come back either at the end of a half-day morning or half-day afternoon. But I think it's a lot about expectation setting. If a patient has an expectation and they have a finite amount of questions, that I will find out what the questions are and make sure to address each one of them to some extent, and anything that's left over will follow up.
That's good.
Yeah, Phillip and Caroline, any thoughts on kind of how much time you felt you had? Do you feel like you got your questions answered, or anything else, any advice you have for patients?
Right. This is so good. I love the answers the doctors gave. If anything, we've learned, all of us in the room have learned over the last 2.5 years, how important relations are. Just the whole relational aspect of life, but now specifically about our medical care. And you're absolutely right. It starts with the first people that come into the room. And what I found is that the more information I can give them about how are you experiencing anything, the more transparent I can be with the first person in the room, allows me to be able to really hone my questions and doctors' answers when they're in the room and they've got a finite amount of time. But I've learned as a glaucoma patient that I now better know what to ask and when to ask it than I did early in my journey as a glaucoma patient. And very quickly, we talk about how much we love the vision field tests. Because we do, we love them. But I will say this, if I can use the analogy of a billiards game. In 2000, my vision field test was the cue ball. Okay. In 2018, my vision field test was the 8 ball. So you understand what I'm saying?
Yeah.
In 2018, glaucoma got much more real to me because I could visually see the progression of the disease. That visual confirmation helped me zero in terms of the questions I would ask John Yang at University Eye Specialist and the questions I now ask Dr. Hawkins, because it became very real. And I knew I had to take ownership of this so that I could manage my disease as I progressed forward in my life and my family life, how I dealt with my kids, my grandkids, and my community.
So when you say real, did you feel like you took it more seriously and were more quote-unquote compliant once it was more obvious that you had lost vision, or were you always very compliant or very kind of clear about what you had to do and taking the drops every day, et cetera?
Yeah, doctor, the answer is yes. No, I wasn't that compliant, but it did get real to me.
Okay.
And my community team, my support team is very good. My wife is outstanding in cutting through all of the noise and saying, are you being good with your drops? Get your drops. Stop staring at that screen so long. Especially when I was finishing a master's, and so I was like this a lot, and I'm wondering why I'm getting eye strain, and just taking better care of me as a patient helped me to understand the importance of compliance, and it became less of a burden and more of a, hey, this is part and parcel of what it is to deal with glaucoma. Yeah?
Agreed.
Yeah, Ken, I'd love to hear your thoughts on the important, and Phillip made a good point about involving family members, involving your surrounding, support structures. Is that important to you, or did you involve your family members?
Oh, yes.
Tell me how
Sure, my
that's
husband's great. He does a really good job at.
We had to say that,
Yeah, but you know what? He's really good at understanding and helping me and to navigating all of these new things I have to figure out. If I can't, it's good. We've made lifestyle changes. We have cut to the chase. What's important? Maybe work's not so important right now. Maybe travel is more important. So that kind of we're able to do those types of things because lifestyle for right now is very important to me. I need to be able to be happy, and I need to be able to see as much as possible while I can and spend time with family and friends. And so that's a high priority right now. And I have to say my husband and my family are really good at that.
That's great. And I think I've also noticed is that a lot of times that when the family members understand the disease process, how it can get worse, and the importance of being compliant, I hate to use that word compliant all the time, but staying on the medications and doing what you're supposed to do, it helps also you as a patient. I've had patients where they come to my office and it was, funny story, not funny, but interesting story, patient comes in and the vision's getting worse on the side vision test, the visual field, and the pressures were kind of going up and down. And I was asking the patient, so you're taking your medications every day, like we always try to do. And his new girlfriend who's living with him sold him out and said, Dr. Singh, he is not taking his medication. He's lying to you. And I was like, oh man, I thought I was such a good doctor, right? So having a support structure can even help you stay on track. So I think that's really important as well. Julie, I'd love to ask you a question about the importance of kind of, you said the advocacy, but how do you get that time with the doctor and make sure the doctor listens to you? I know it's not fun. We had a patient earlier at lunchtime saying how sometimes they don't feel comfortable that the doctor doesn't give them the time of day that they need, even bringing up, let's say, opportunities for research, and said, no, I'm the doctor, I know what I'm doing, kind of thing, and like second opinions. How does all that work?
It's interesting. I had a chance during the break to talk with Patricia, I love her story. It's so compelling. Life is a funny, like Sonny Liston said, life a funny thing, but life is maturity is a funny thing. Where you have a disease that you know is progressive and that we know there is no known earthly cure for it, that has a tendency to focus you. And so you become less concerned about societal positioning. Where oftentimes we go into a doctor's office and it's, oh, yes, doctor, and you don't want to say anything. Well, when you realize that you're going to be dealing with this for the rest of your life and you have to advocate for yourself, then you no longer have that problem of coming to your doctor and seeing that doctor as a human being and saying, look, help me deal with this. What can I do? I trust you. And I said that to both Dr. Hawkins and Dr. Yang many times. I've had 7 surgeries, 2 in this eye and 5 in this eye. Before each surgery, I would say to Dr. Yang, I trust you. Give it to me straight. And we sometimes, I think, as patients, just have to be secure enough in our management of the disease to be able to look at our doctor and to look them, quote unquote, in the eye and say, what's going on? What's the story? What's the deal? Tell me the risks. Tell me the benefits, and then together, like Zig Ziglar used to say, you can't change my mind, but you can give me enough new information that I can make an informed decision.
I love that. Giving the patients enough understanding of the conditions to let them make the informed decision. If we just say, here's a drop, it's going to cost you X amount of money. We're going to talk about costs as well in a second. If they don't understand as a patient what's the benefits, what's the ramifications of not doing it, how do we expect them to pay for something or do it? And to that point, Julie, how do you approach a second opinion? Is that a bad thing? Is it a good thing? And should patients feel bad about trying to get a second opinion?
That is such a great question. Absolutely not. I think, I love everything that Phillip and Carolyn have shared so far. Finding a second opinion, I think of it like this. Every one of us are different learners. And so when we go into the office, the clinic office, and we don't get the information we need, and maybe we don't realize it at the time, or we don't know what questions to ask, but something doesn't feel quite right, and we're coming up upon a big decision that needs to be made, and you still don't have all of what you need. I think you don't have to feel bad about reaching out and finding a second opinion, I think as a culture, we're very much, and Phillip alluded to this, it's medicine, historically is very much like very hierarchical, very much like, the physician telling the patient. But I think, we have to remember that, yes, absolutely, they are the expert in the medicine, but patients are the expert in their own experience. And there is, as you alluded to, Phillip, it's that relationship. And it's the doctor helping you and, getting, as you said, tell it to me straight. It's also the patient needing to tell it to them straight as far as, I'm not compliant, I haven't been doing this. And, as embarrassing as that can be, it has to be honest in order for, it to be this truly therapeutic relationship. And so when it's, it's okay, and I think there are certain generations and certain cultures that definitely say that, my parents, for instance, Dad was just, getting a surgery, and I said, "Did you reach out and get a second opinion?" And they said no, and they're 80. I think it's just not something that they didn't want to be deemed as a difficult patient. That's something that's thrown around a lot. And I would just say that it's simply about getting all of the information you can get, and however you get that, you don't need to feel bad about it. It's your right as a patient. And as going back to the different learning styles, people have very different communication styles, providers do. And if it doesn't work for you, it's okay. It's just like dating, it's not always gonna work. And so it's okay to move on and find somebody different.
And I'd love to ask Dr. Rosenberg and Young, what are your thoughts on second opinions? I personally think it's great because I know when a patient goes to the doctor and feels like, hey, the same plan of action, then we all feel like we're on the same page. Your thoughts on second opinions, Dr. Rosenberg?
Yeah, I think that a couple reasons, at least, for a second opinion. One is to get a fresh look by another set of eyes, especially in perhaps complicated cases, or when you're facing surgery, or if your doctor is not answering questions to your satisfaction. I want to highlight something that you said. I often find myself saying to my patients, particularly when I suspect noncompliance, is, please, Mrs. Jones, tell me if you're having a trouble with the medicines, because you don't have to say you're taking them just to please me. That is not what I'm about. If you have trouble for any reason, physically instilling the drops, cost, remembering, whatever it is, just let me know so I know what I'm seeing here in your condition, and I will tailor your treatment accordingly. I'm not going to force you to take drops if you have a difficult time with it for whatever reason. And so it's a partnership. It's a two-way communication street between me and my patient with this long-term relationship of dating. and so any physician or eye care provider that would balk at getting another opinion would be cautionary to me. Mm-hmm. And when I see a patient for a second opinion, I ask the patient, did I answer all your questions? And if you ever want to, call me again or see me again, but your doctor's doing, a fine job, or whatever steps you want to take going forward from there.
Oh, that's really good points. We have 4 minutes, almost 3.5 minutes left, so a few more questions and we're going to wrap it up, unfortunately. This is great stuff, by the way. Dr. Young, there's a question here about drops being expensive. We understand cost is a very big issue. I know and everywhere we practice, I think that's a common theme. Any advice on that? Any kind of programs or anything you suggest from a cost perspective to help with drops?
Good question. Most of the drug companies are aware of costs and are constantly lobbying to get on insurance panels for coverage. Many of them provide samples. Many of them provide patient assistance programs. Most of your doctor's offices have those resources, or the manufacturer may have that resource on their website. Definitely an important issue when it comes to healthcare at this point is cost.
I'd love to ask a couple of questions here on just overall last thoughts from Caroline. Is there something you know now, having glaucoma, then that you wish you had known before, whether it's just asking questions about what to do or just any advice you have that you could have told yourself from a few years ago?
I think the most important thing is speaking to your doctor, giving them all of your concerns, and asking if there's anything new out there that you can try. And I, because of that, have done the at-home eye care tonometer 3 times now, just by renting it. It has provided valuable information to the doctor and gives me peace of mind. So much so I'm going to buy it. So
There you go.
There you go.
Phillip, what are your thoughts on something you know now that you didn't know then?
What Caroline said was so true. I would say, just to keep it short and sweet, a diagnosis of glaucoma is not a death sentence. It isn't a death sentence. You know, I said this to you earlier, Doctor. I have been able to now, reflectively, been able to say, it's a uniquely wrapped blessing for sure, but it is a blessing. And I think if we can look at this, if I had known in the year, 2000, the benefit that I would have to other people's lives, inspiring other people, and the insight that losing my sight has given me, then it would have helped me to possibly be more compliant, but certainly to be a little more positive along the way of this journey with glaucoma.
It is a journey, no doubt. Julie, thank you for that. Appreciate that. Any last comments you want to share with the audience?
I think the importance of finding community. Just that immense benefit on being able to take care of yourself. Yes. Invite people, your army to come with you to the doctor's office, whatever support you need to help you take best care of yourself. But I think it starts with finding that community, and that's also your healthcare providers included within that community.
That's right.
Too.
And last two docs, any comments you want to share with the audience before we go? Dr. Rosenberg?
I think I'm
Pretty good? I'll give you the opportunity, Dr. Young.
Thank you. I like the community. It's all about community, and everybody wants to do what's right for you. It's communicating so that we know what we can do best.
Well, with that said, I really appreciate this. Is fantastic to hear everybody's comments and kind of your perspectives from as a patient, as a doctor, as an advocate. So thank you for that, everybody. It was wonderful. Really appreciate that. Thank you so much.